Dear Chairman, ladies and gentlemen, our case is about a 77-year-old male who was transferred from another institution to our hospital in a very bad condition. He had a congestive heart failure in New York Heart Association Class 4. He was hospitalized there for 2 weeks with acute heart failure and pulmonary edema. The initial diagnosis when he was sent, it was severe primary mitral valve regurgitation. The patient has a known history of coronary artery disease. He underwent multiple PCIs 20 years ago. And in 2013, he underwent bypass surgery with Lima to LED and vein graft to the distal RCA right PDA, surgical aortic valve replacement with Sorin mitral flow, 23 millimeter, and surgical repair of the ascending aortic aneurysm. Unfortunately, in our island, a center used exclusively mitral flow, Sorin mitral flow, more than 100 cases per year. And it's still an issue because all these patients are coming back with the degeneration of the Sorin valve. And at least here we're lucky because in this case, we had 2 grafts and the coronaries were relatively protected. The patient had also peripheral artery disease with stenting of the ostial proximal part of the common iliac artery in 2012, chronic renal failure, diabetes mellitus, and hypertension. This is a portable X-ray that was done immediately after his admission and the bedside ECG. And here is the laboratory workup showing anemia, NT-proBNP of 5,300, no evidence of infection or sepsis, and high creatinine levels. This is the bedside transthoracic echo showing dilatation of the left ventricle and relatively preserved ejection fraction. A mitral regurgitation which was central, looking as a functional, and some flow from the bioprosthetic valve as an eccentric jet coming next to the anterior leaflet of the mitral valve. This is a transition vagal echo that was done 1 hour later, showing that the mitral regurgitation was not so severe, at least with the color. The X-plane showed that there was no any prolapse or flail of the mitral valve, once again showing that the mitral regurgitation was not so severe. And there was an eccentric jet coming from the bioprosthetic degenerative valve towards the anterior leaflet, the ventricular aspect of the anterior leaflet of the mitral valve, especially in the right upper video. You can appreciate that in the deep transgastric view, there was a significant aortic regurgitation of the degenerated bioprosthetic valve, the Sorin mitral flow. CT was also done the same day, a few hours later, showed that the stent of the iliac artery was patent, though it was obviously undersized. There was severe diffuse disease of both sides of the iliac and the external iliac arteries, and a lot of calcium located at the site of the punctures. We have a brief discussion with our vascular surgeons. We both decided that this case was not a good case for transfemoral axis. Even though that we very rarely reject patients from transfemoral axis, we use lithotripsy, as the case was showed before, and multiple other facilities in order to proceed with transfemoral axis, but in this case we decided that this patient was not a good candidate for that. Fortunately, the CT shed light on the subclavian and the axillary arteries, both sides, and showed that the axillary artery and the subclavian artery had good dimensions, no extensive calcium, no tortuosity, and the angle between the left subclavian artery and the aortic arch was less than 80 degrees. These are the Euro score 2 and the STS score, which, as expected, was extremely high. We discussed with the heart team. We decided that this patient should be treated with TAVI, valve-in-valve, as soon as possible, as the patient is still unstable. The plan was to use conscious sedation, as we used regularly, a 7 French cylinder sheath into the right radial artery, the left radial artery, to perform coronary angiography and control of grafts, to use a safety guide wire of V18, a 6 French right radial sheath to be used in the right radial artery for the hemodynamic monitoring, the orthography. And we decided to go with a transaxillary approach, ultrasound-guided micropuncture, and then an 8 French sheath insertion in the left axillary artery, a single pro-style closure, which is actually our strategy in transfemoral axis too. We don't use two proglides for at least 2 years now. A Landerquist extra stiff guide wire for better support, and to implant directly an Evolut FX 23mm valve, and then to try to fracture the stent of the valve with post-dilatation using an Atlas Gold 22mm balloon. Coronary angiography and control of grafts was performed with only 30 ml of contrast, as we have to prevent this patient from contrast-induced nephropathy. The lima was patent. We knew that from the CT that both grafts were patent, but we noticed that at the distal to the anastomosis of the vein graft, there was a critical lesion of the proximal part of the right posterior descending artery. As the patient has no any angina and his symptoms are purely symptoms of heart failure, we inserted the sheath in the transaxillar, in the axillary artery. We performed an aortography, just once again showing that there was a massive aortic regurgitation, and then we implanted directly an Evolut FX 23mm. We post-dilated with Atlas Gold 22mm balloon. We didn't perform even an aortography after we finished because we noticed that the diastolic pressure increased from 40 to 70 millimeters of mercury. We did a transthoracic echo, which showed no leak. And we transferred the patient to the coronary care unit. The ECG was fine. The chest X-ray improved significantly within 2 days. And 5 days later, we performed PCI to the anastomosis of the distal anastomosis of the vein graft with a nice result. This is the transthoracic echo showing zero paravalvular leak, mild mitral regurgitation, which was decreased significantly, and the peak gradient at the aortic valve of 18 millimeters of mercury. The patient was discharged on day 7, and 6 months later, he's in very good condition. Thank you for your attention.
A very tough case with very difficult decisions. Yes, Dr. Maginas?
Congratulations, a difficult patient with several comorbidities, difficult access, severely degenerated aortic prosthesis. I agree with your approach to the subclavian artery. I agree with the direct positioning of the FX valve. I think you saved this patient. You provided excellent service to this patient. Congratulations.
Thank you.
Just before to ask from Professor Tsikas his comment, why did you see the carotids so as to use the carotids?
It's a very good option, carotid approach too. We don't have experience in our center. Even our vascular surgeons, they are not experienced in this field. It's an option, of course, because unfortunately, transaxillary approach has a little bit higher risk of strokes. This is true. Even the transcarotid access, which is it appears to be more dangerous for strokes, is not so high. But in these cases, we always have a good cooperation with vascular surgeons, and we both decided that transaxillary access was, for both of us, more safe and more effective. That's why we choose the transaxillary access.
Was just because of the internal mammary?
Yes, it's true. There is a relative contraindication to use transaxillary access in patients with patent lima. In our case, the diameter at the level of the origin of the lima was more than 8 millimeters. So there was no any calcium there, and was the lumen of the vessel was good enough in order to proceed without high risk of obstructing the lima during the procedure.
Professor Tsikas? Professor Tsikas?
I have to congratulate on Dr. Georgiou. Really a combination of a lot of issues to resolve. A very high risk valve as mitral flow. We know that there are a lot of issues regarding the management of these valves. You decided, of course, to use a self-expanding valve. Why not a BEV to this case? Why not?
Yes, balloon expandable valve can also be used through the transaxillary access. There are no limitations to use balloon expandable valve. Of course, it's a sheath that will be used, will be expanded, and sometimes reaches the 8 millimeters of diameter, although it's a 14 French sheath. It can be used. We don't have experience. At least with transaxillary access, all the cases we have done, at least 5 or 6 cases, are all cases with self-expanding valve. It's something that is doable, depending on the experience of each center. And then I think both of them can be used.
Do you have any experience regarding ring rupture before or after the case?
Excuse me,
if you believe that you need it? Ring rupture, if you need it, if you have a very tight ring.
No,
we don't. One, I mean.
No,
if you need to rupture it.
The ring capture? I didn't understand your question.
Rupture.
Fracture. Yes, actually we did fracture of the stent. We used Atlas Gold balloons according to the application of the valve-in-valve technique. It's very important to insist to increase up to 14 atmospheres and to wait until you feel that the inflation device manometer pressure is going down. This is the sign of the successful. Sometimes it's difficult to estimate the real fracture with angioscopy. It's not easy to do it with screening. So you have to note that the inflation device is coming, the inflation device manometer is coming back from 14 atmospheres to 6 atmospheres, for example. This is an indicator of a successful stent fracture of the valve. And it's important to do it because it's not for the patient's benefit to leave a gradient of, for example, of 25 or 30 millimeters of mercury. It's a ppm, significant ppm, and it's important to decrease in the minimal acceptable degree.
So you prefer to do it before the...
No, we do it, you used to do it after the valve implantation.
Okay.
For safety reasons. I think it's more safe to go after the valve implantation.
You feel the fracture and sometimes you hear the fracture.
Yeah.
Okay, Dr. Taleb?
Congratulations, Dr. Georgiou, very challenging case. A very short comment. Anytime we assess and we try to define risk, on a case, obviously TAVI has less risk than open heart surgery. This applies though only to the transfemoral, so the benefit of TAVI is only the transfemoral. Anytime we change access, either it's subclavian, direct aortic, carotid, we cannot really have a good estimate of how better or how lower risk are we making this case. And especially the transaxillary with a lima there, it always, no matter how good we are, we can still pose some risks.
On the other hand, I don't believe that there is a surgeon who would accept this patient to have a redo surgery with a surgical aortic aneurysm repair, with valve replacement and lima beyond the sternum. I think this patient in a very critical condition, I think there was no way for surgery for this particular patient.
Dr. Sparias.
That every time you move to another access, you go higher at risk, but that was no other option patient, clearly. So you did it very well. Congratulations. What was the size of the stent? Because in the reconstructed images of the CT scan, the peripheral vessels appeared large. So
I think it was a 9 millimeter stent, but the size of the vessel was even larger. And the external iliac arteries and the common femoral arteries and the external femoral arteries, both of them were severely calcified. So the main problem was not within the stent, that could be, you mentioned the stent of iliac artery.
Yes, the left side.
Yeah, left side. I think it was 9 millimeter in a vessel which was almost 12 millimeter before the surgery, before the stent. According, it was a big size vessel, but both external femoral arteries, external iliac arteries and common femoral arteries were diffusely diseased, severely calcified, and that's the reason it was rejected for the team, by the team.
Right. We have done cases like this, very borderline cases, through grafts, through peripheral stents, with low diameters and calcifications. So I would have tried the left side with dilators and the ECIF, and if the ECIF would go through easily, I wouldn't push to rupture vessels, then it could be transfemoral. And if that failed, then I would move and do exactly what you did. It's just another option.
Okay, thank you, Dr. Spider. There is a question from
just a quick comment.
2 questions from the audience.
Dimitris Kalvriziotis, I'm a cardiac surgeon from Quebec City, Canada. A great case, Dr. You were very complicated. We've done more than 700 TC and published. Obviously, TF is our axis of choice. If TF is not possible, we go to TC. And we're very scared to do patent Lima to LAD by transaction layer. I think it's dangerous. I think if you get into trouble, the patient is dead. So TC is not higher risk for patients that are not candidates for TF. It's not higher risk than TF. The problem with the TC patients is that they're so sick. TC patients, I tell the residents and the fellows, are the sickest patients in the hospital. They're not TF candidates. So it's very hard to adjust out the risk. But once you do, by propensity score methods or whatever, you actually get a stroke rate that's similar to TF from TC patients. Once you adjust out the fact that these patients are very, very morbid. So TC is a very safe, and we've published this extensively from Professor Obadiah's experience in Bordeaux as well. TC is a very, very, very safe choice. And I think the current guidelines, whether European or American, clearly say that for candidates who are not TF candidates, you should do SAVR, which makes no sense to me, since we have alternate access that's safe. Thank you.
In the last 2 years, TC is our preferred alternative access. So if we cannot go transfemoral, we're doing transcarotid. So just to add,
Yeah.
and this is, we reached this conclusion and practice independently from our own experience.
Wonderful.
Congratulations. As you mentioned, one of the most hardest part of this case is the presence of a mitral flow. And you were lucky that the patient had a bypass surgery because since the leaflet stood outside of the stent, there's always risk of coronary obstruction. And for example, if this patient have not bypass graft, maybe it was better to do basilica.
Leaflet modification.
Yes, basilica, and then use the femoral wave by using shockwave lithotripsy, as you underlined.
Even the 4 millimeter distance, VTC distance, that is the cutoff, is not so safe in these cases. Sometimes you may have an occlusion of the left main, which is catastrophic. Yes, you're absolutely right.
Okay, thank you very much.